Since there is no rigorous data supporting a protocolized approach to investigating fever in ICU patients, the preferred clinically driven and cost-conscious protocol includes the following initial investigations. Blood cultures from 2 different sites drawn prior to initiation of antimicrobials. When central intravascular catheters are present, blood cultures from the catheter should be drawn. If infection with fungus is suspected, blood should be used to additionally inoculate fungal culture bottles. Respiratory tract sampling for febrile patients, which includes endotracheal aspirate or sputum gram stain and culture, on the condition that sampling is feasible. Urinalysis and urine culture for febrile patients in the ICU, predominantly for those who are catheterized, have renal pathology or are immunosuppressed. A chest radiograph, which can identify a novel or progressive pulmonary infiltrate, distinguish pneumonia from tracheobronchitis, or detect a respiratory source of fever other than pneumonia or tracheobronchitis, which would otherwise be missed since it is not associated with sputum production. However, chest radiographs are insensitive, particularly in those with existing radiologic abnormalities, since new findings may not be easily detectable. In such cases, chest CT may be required to detect new infiltrates or lung abnormalities accountable for fever. Such testing is considered inexpensive, easy to perform, and targeted at the common and additional severe etiologies of fever in the ICU patient. If epidema is suspected when the indicated microbiologic cultures from suspected sites of infection, including wounds, catheters, fluid collections, joints, stool, or sinuses are prudent, the cultures should be drawn directly from the pleural space instead of the catheter. If the fever occurs throughout transfusion and the transfusion is terminated, then the transfusion bag and its contents should be sent for culture. Laboratory studies or the investigation include routine complete blood profile or obtaining count and chemistries comprising lactate measurements. Evaluation for sinusitis is appropriate for mechanically ventilated patients who have purulent nasal drainage, or whose evaluation has otherwise been entirely negative. Another commonly considered test for investigation is abdominal imaging. This imaging is indicated for patients with symptoms or signs of an intra-abdominal process, like distension, tenderness, or absent bowel sounds. Other laboratory tests are focused at specific suspected etiologies, like suspected thyroid storm of thyroid-stimulating hormones, T3 and T4, suspected acute hemolytic transfusion reaction, suspected adrenal insufficiency. Moving on, we will consider the management of fever in ICU patients. The management of fever done in ICU patients includes the following. Its foundation is to treat the underlying cause of the fever. In addition, the clinician would need to decide whether antimicrobials, catheter, or device removal and treatment of the fever is indicated. Let us now explore each of these factors in detail. Treating the suspected underlying cause. Treatment of fever should be directed at the suspected underlying cause. Choosing to start empiric antibiotics. In some cases, empiric antibiotic therapy is initiated, while in others it is delayed until the fever returns. This decision is subject to significant judgment and weighs the risk of delaying therapy against the unnecessary use of antimicrobials. Generally, empiric antimicrobials are prescribed when infection is suspected, especially in patients with temperature greater than or equal to 38.9 degrees Celsius or greater than or equal to 102 degrees Fahrenheit, and in patients who present sepsis or shock, neutropenia, are immunosuppressed, or have devices that are suspected to be infected. For most other patients, further diagnostic workup with ongoing clinical assessment prior to the initiation of antimicrobial therapy is reasonable. Deciding to remove catheters. Choosing whether to remove an intravascular catheter or other device in a febrile patient is challenging. Considerations in the decision to remove an intravascular catheter include the severity of illness, age of the catheter, probability that the catheter is the source of fever, and consequences of catheter removal. For example, in a patient with sepsis, Removal of an intravascular catheter when the insertion site looks infected is appropriate. While removal may not be necessary if the insertion site is clean and the catheter has only recently been inserted. Removal is also appropriate if the catheter is known to be infected, or patients have evidence of metastatic infection, or persistent bacteremia, or fungemia of the catheter. For example, it should be removed if the patients have evidence of endocarditis, particularly with pathogens including Staphylococcus aureus, Pseudomonas aeruginosa, drug-resistant organisms, and Candida species. This table shows the presumptive antibiotic therapy for ICU patients. Routinely, fever is treated with an antipyretic, like acetaminophen, on initial presentation. Its administration should follow the course of the fever over the next 6 to 12 hours, while investigations and cultures are impending. While there is a lack of data, protocols that systematically avert and treat fever in the ICU patients appear to offer no benefit. Most experts agree that aggressive or prolonged cooling with external cooling blankets or ice packs and the use of mechanical methods to prevent further recurrence is not necessary, unless the fever itself is considered harmful. For example, in patients with increased intracranial pressure, or excessively high when fever is greater than or equal to 41 degrees Celsius, 105.8 degrees Fahrenheit. For example, if body temperature exceeds the critical thermal maximum, which is thought to be between 41.6 and 42 degrees Celsius, 106.9 to 107.6 degrees Fahrenheit, life-threatening complications can follow. For example, rhabdomyolysis. When treating fever, most experts choose acetaminophen rather than nonsteroidal anti-inflammatories, or NSAIDs, or aspirin. Whether intravenous or enteral acetaminophen should be used is unknown, although oral administration is preferred when feasible. Several studies report that the incidence of hypotension is higher after a parenteral acetaminophen as compared to an enteral administration. Now we will cover the basic steps for a follow-up to fever in ICU patients in the next slide. Management at an ICU setting results in the improvement or resolution of fever. Patients should be followed up, and if antibiotics are administered, they should be tailored according to the culture results. However, if in a small number of cases the fever persists or worsens, additional studies targeting a suspected etiology should be considered. For example, a suspected etiology could be persistent bacteremia from an infected device, drug fever, osteomyelitis, pulmonary vasculitides, tumor, or venous thromboembolism. These investigations range from bronchoscopy to lung biopsy and may also involve extensive radiologic imaging, lumbar puncture, bone biopsy, and serologic testing. A cause is not found in rare cases. We have reached the end of this session. Let us recap some of the key points discussed. The incidence of fever is common in ICU patients. The fever is identified as the body's host defense mechanism, although it is commonly associated with infections.